invite Dr. Elankumaran Pasupathi. Now, all of you know he is the director of AIOC2024, passed out from All India Institute, practicing for the past 20 years as director, AIOC2024, Bangalore. He will be talking on the right oil for the right patients, how to choose from the various technologies available.
Either. इसमें नहीं जाएगा बस Thank you, Dr. Umesh. And again, I would like to thank the audience. We were thinking there will be no audience for this last session. Thank you for staying back. Dr. Kumaran spoke about angle kappa, about multifocal, trifocal IOLs, and there was a talk on advanced monofocal. Thank you, Dr. Kumaran, for covering it. Our speaker is getting delayed. He is still not come here. Now, we have these options. How do we decide what we are going to use? That's going to be the gist of my talk. He spoke about angle kappa. I'll be talking about something else which you can use to decide which lens to use for which particular patient. We have varied lenses, EDOF, trifocals and monofocals. Now mind you, that middle one, the monofocals also, we have got some patients at least who have had 6/6 and probably N8, may not be N6, N8. There are many patients happy with this. What is the reason for this? Have anyone thought of? It's not just astigmatism. Something else is also playing a factor, and that is what is used by IOL manufacturing companies to produce this advanced monofocal lenses. Now, what is the most important thing that you have to consider whenever you think about giving good vision to the patient? The first thing you look at is the toricity. Now, we have been traditionally taught that a toricity of more than 1, we do not use advanced lenses. But then, when it comes to multifocals, EDOF is slightly forgiving, but advanced monofocals or multifocals, trifocals, please consider this value as 0.5. But why did I put up this slide particularly? Right side, sorry, the pointer is not working on this thing. Right side, you can see the astigmatism is 0.72. So there is no question that you have to use a toric IOL, if at all, if you are using an advanced IOL. But look at the left side. The toricity is 0.13. But what happens when you feed it into a Barrett toric calculator? Look at what's happening. The Barrett toric calculator says, please use a T2 to get a proper value, T2, toric lens. So, point to take home from here, always get your readings, put it, feed it into the Barrett toric calculator. It's free, it's available free on APS-ERA's website. Feed it into it and then decide whether you want this patient to undergo a toric lens or not. This is something we have been following for the past 2 years and we have been getting very good results. Now, this was one of the reasons for all the unhappy patients. Also remember this, it's not just the IOL. The companies can talk about their IOLs, that their single IOL is the best. But then it's not just the IOL that decides this vision of this patient. Before you think about going into advanced IOLs, look at what the other things are like. Plan advanced IOL only in the normal eyes. If there's a problem elsewhere, be it the cornea, retina, or in between, even if there are floaters, a lot of floaters in the vitreous, please avoid an advanced IOL in these cases. Also, whatever instrument you have, hit this patient with that. See if everything is normal and then decide about your advanced IOL. Something which we all miss in our busy OPD, dry eyes. The most important things that creates problem in the post-operative period is the dry eyes. Look for it. Assess the need of this patient. Need of the patient, I'll be coming back to it in the last slide. The patient might want a lot of things. He wants a 6/6, N6 vision, but assess the need. How do you do this? Need means what does it really require? Ask for his profession. Ask for his hobbies. Now, there are questionnaires available on the website. The first one, what you see, is a Speed 2 questionnaire. This was designed entirely for insurance purposes in US, where it talks about advanced IOL. But look at the second questionnaire that goes into what is the daily activities of this patient, what is he using. have this questionnaire, or at least you can talk to the patient couple of minutes. Your counselor will not be able to talk about this, and then decide what to use. Now this is what I'm going to talk. Forget about everything else. Look at this particular chart. It's difficult to get, I mean, it's usually found in some machines, topographers. Pentacam is what I have. And what is that small circle there? That's a spherical aberration. Before I began this talk, I said IOL companies utilize a particular parameter. They have been using the spherical aberration to bring in some amount of extended depth of focus in monofocal lens. So how do you use this spherical aberration? Before I go to that, if any of these parameters are above this on a pentacam, coma, total aberration, spherical aberration, above these values, these are normal values. If it is above these values, please do not think about, again, advanced IOLs. Go for simple monofocal IOL. Now, asphericity is what I was talking about all this time. We know that the cornea is aspheric, but then it follows a parabola, and what is 0.53 or asphericity is considered to have no spherical aberration, zero spherical aberration. But do we all have that zero spherical aberration? We'll come to that. But before that, a person who doesn't have a machine, what does he do? Now I have a pentacam, and this is where I look at. That's the value I use for the pentacam, and this is where I look at. Look at that area. Spherical aberration in the 6 millimeter zone. Now in this case happens to be 0.522. If we take this value as 0.6, then he comes within that range. But that's not our goal. We want to use this spherical aberration to proceed and give freedom from glasses to all the patient. The best machine to calculate this, of course, is an eye tracy. I do not have it. If you do not have a pentacam, please talk to a friend. You can send him there, get it done, and come back. And then go ahead with it. Now, in a cataract patient, this is copied from Dr. Uday Devgan. If it is just simply speaking, if it is a hyperopic LASIK, which has been done previously, then go for a non-spherical, the traditional IOLs. Traditional IOLs, which was positive asphericity, go for that. Now, if there is a prior myopic LASIK, choose a negative asphericity. No prior surgery, then the problem comes. If there's a likelihood of IOL decentration, such as pseudoexfoliation, Marfan's, or one of those disorders, then think about aspheric IOL with the thing. IOL not likely to decenter. This is the place where we have to decide. Now there are two options here. You have already seen the profession of the patient. You have seen his activities. So, if the patient needs crisp vision, then you go with the slight negative asphericity. How much should it be? Minus 0.1. If the same patient needs depth, meaning he can adjust a little bit of reduction in the contrast, little bit of reduction in the quality, but he needs the depth with that lens, then you go for minus 0.25 to minus 0.35. Remember these two values. 0.1 gives crisper vision. This is the total asphericity, not just the cornea. I'm talking about the total asphericity. Now 0.1 gives crisper vision. 0.25 to 0.35 gives the depth of vision for around 1 to 1.25 diopters. Look at these two values, then we will see how to do it. Like, a normal cornea is not zero. It is around 0.25 to 0.35. So nature has already given this to us. This is one of the reasons why a child's cornea can give a certain amount of depth of vision, also providing clarity in vision. So remember this. And in our patient, this was minus 0.52. We'll take that an example and calculate later. Now, when you consider this, in that normal range, you can go for any premium lens confidently. Target, if you're going for a trifocal lens, already this multifocality is provided by the trifocal lens. If you're using EDOF, again, EDOF is providing that multifocality. So what should our target be? cornea, let us say, is 0.5. We have to use a lens with a spherical aberration of 0.27. There is a lens. Highest we have is 0.27. I'll be coming to that. 0.27. So what are we doing? Say 0.5, 0.27. We have brought it down to almost 0.13 to 0.2, closer to 0.1. So we are targeting crispness, but multifocality is provided by other technology. Okay, any doubts on this? You can ask me, because it's slightly confusing. I took almost 3-4 days to learn this. So if you are providing trifocal lenses, target that 0.1 final. How do you do this? Just like what Kumaran said, take the lens or ask the person what the asphericity of that particular lens is, match it with the cornea and produce this 0.1. By chance, patient is not affordable. He wants to go with a monofocal IOL or an advanced monofocal IOL. I'll take a little bit of time. There are some speakers not there, so I can afford to. Patient cannot afford. He wants to use a monofocal lens or an advanced monofocal lens. What should the target be? The target finally should be 0.25 to 0.3. So our patient have 0.52. When you put in 0.17, there's a lens available with that also. I'll be coming to that later. I'm not going to name any lenses. I'm only going to give you values. Please find out from your distributor. Indian lenses are available at 0.19. So you can use any of these two lenses and bring that value within 0.25 to 0.35. This is what we have to do if we are using an advanced monofocal IOL or a monofocal IOL or even a trifocal IOL to produce good vision. So, if the spherical aberration is beyond that range, try to avoid this multifocal trifocals. EDOF can be used, however, talk to the patient and use this value to your advantage, and you can use an advanced monofocal IOL. This slide sums up everything. The first one, where these spherical aberrations can be classified as toxic and non-toxic. Toxic, where it's going to create trouble to the patient. Now in those cases, avoid premium at any cost. The top one and the bottom one are the toxic ones. You can look at it. The in-between ones, definitely in the normal range you can use anything close to it. You can play around with the spherical aberration and bring it to this level. This is one thing what I have started doing in the last 2 years, and I've been getting good results. Now we spoke about the cornea. 0.25 to 0.35, say that is the normal limit. But then lenses are available. The traditional lenses what we were using were plus 0.15. Now you understood why that is required for a hyperopic classic. In a hyperopic classic, we are inducing negative asphericity, so that's why that is required. The maximum asphericity that is available is 0.27. I'll just name the lens here, that is Technis, in case you need that. Minus 0.2. In this, actually there is a range from 0.17 to 0.2. Indian lenses, the IOCare lenses are available here. Alcon lenses are available here. 0.17 is Alcon, 0.19 I think is IOCare. You can just confirm with the value, write it down, so you can use it in this range. So, person with 0.5, if you want multifocality, use this 0.2. If you want good focus, use the 0.27. And there are zero asphericity lenses. Rayner, what Dr. Subhash Prasad sir was talking about, is a zero asphericity lens. So ask the distributor, read the box. Zeiss also is a Zeiss, Zaracom, lot of lenses are zero aspheric lenses. So you can talk to them and use it to your benefit, and you can give a reasonable amount of multifocality to all the patients. Sorry, slides are going back. Now, finally, I would like to talk about, I've already spoken about this. It's not just the occupation of the patient. We are beyond a stage where only work is a criteria. Many of them have such exceptional hobbies which we forget to ask. So always ask about it, and then you decide, then you counsel the patient. Dr. Kumaran was talking about a particular patient who comes and says he needs 6.6, N6. There are many patients who come because they know these two values. That patient never put in an advanced IOL because he is going to be the biggest troublemaker. Try to talk to him and say, whatever lens I am going to insert, there is going to be a residual power. defocus curve was discussed before also. Just look at this defocus curve. Anything what you use, there is a residual power. Let's remember that. Anything what you use, you're going to have dysphotopsia. Remember this. How do we reduce it is what is most important. Again, this is copied from Dr. Uday Devgan's website. You can go back and see this. Now, to get a refractive success, assess that wants and needs. Patient may have 1,000 wants, see what he needs. Rule out all our pathologies in the eye. Look out for dominant eye. This is something which I forgot to tell. I think all of us know how to look out for a dominant eye. Simple test, you can just do this and ask him which eye he is focusing. Usually that is the dominant eye. Match the Q value, rule out the aberrations, communicate, document that communication, and then go ahead. Money is very important, but that's probably the last one to consider. Also, spend a lot of chair time with this patient. Thank you for the opportunity provided. Any questions I would like to take?
Yeah, thank you, Ellen. I think very wonderfully he's clearly described about all those things, especially the asphericity. And sure, those who have Pentacam, you have to buy the additional stuff. Those who have Pentacam, they have to buy the additional software for that, but those who don't have, you can try to